Good morning and welcome to Veterans Heartbeat on the Pulse of the Veteran, where we discuss issues of health, happiness, opportunity, and well-being of interest to the veteran community, their families, and the community who honors them.
Good morning and welcome to another episode of Veterans Heartbeat, brought to you by River, the Rural Institute for Veterans Education and Research. My name is Jason Zencraft. My co-host Ed Lisofsky is here with me, and he is the Executive Director of River. We welcome you to a weekly wide-ranging discussion of issues, events, opportunities, and needs in our veteran community. Morning, Ed. How you doing?
Morning, Jason.
We'd also like to thank our sponsor, Farside Signs. They create amazing-looking vehicle graphics that will drive traffic to your business. Follow them on the web, Instagram, and Facebook, or just stop on by.
Well, good morning. This morning we have Glenn Terry, a retired orthopedic physician that moved to Roatan, Honduras, and started a stem cell research center in Roatan. Good morning, Dr. Terry. How are you doing this morning?
Good. Good morning to you, Ed.
So, I'm excited to delve right into this subject. Why Roatan, Honduras? We're seeing a lot of problems with the VA up here. Not following any of the research that they've done. We know that there's a lot of red tape for treatments in the U.S., so why did you decide to go to Roatan?
Well, initially, we moved to Roatan thinking that it would be a beautiful retirement place, and we purchased a house here several years before I retired. And then once I retired, we moved down here, and after we arrived here, friends that we had met and known for 2 or 3 years since we had purchased a house impressed us with the medical need for the local island, and we started looking into it, and we decided that stem cells would be a really appropriate direction to go, because I have always been interested in the molecular aspects of orthopedic treatments and how important they were to the ultimate success of any operative procedure. And then coupling that with the minimally invasive tendency that started in the 1970s towards arthroscopy and minimally invasive surgery as time went on, we felt like that the next step was regenerative medicine from a cellular basis, and stem cells provide that opportunity. So we also wanted to be legal, and it was illegal at the time, and actually still is illegal, to process the tissues that we process, even though we minimally manipulate them. The FDA has indicated that it's illegal to isolate cells from any tissue, blood, fat, bone, and re-inject them into joints or areas of injury. So we wanted to do things legally down here, and we did obtain all of the permits required and Ministry of Health permits to be able to function in a legal capacity.
Wow. Okay, so let me get this straight. From what I understand of what you do, you take things out of the cell, out of the fat. Am I right?
Yes, we prefer fat. We can harvest cells from different sources, but 1 milliliter of fat provides 500 times more stem cells than bone marrow, and bone marrow provides more cells than blood. So that's why we prefer fat.
Okay, so you take some fat, you process it in the lab, and you re-inject it. Essentially, that's what you're doing, right?
Right. We discard the fat cells, which sounds wasteful, but they can create an inflammatory response. So we discard the fat cells, and then we emulsify some of the tissue remnants that provides the microscopic niche that the stem cells live in. And along with the stem cells, there are multipotent cells that are attached to the vascular structures, and there's also growth factors, and there are cytokines, which are proteins that help direct the stem cells. And all of this provides a signaling capacity and provides an extracellular matrix and provides the stem cells. We also add back into this microvascular niche that's been emulsified isolated stem cells to increase the stem cell numbers, so that when we then reintroduce those as an injection to a specific site that we've identified as needing help, then all of the signaling and all of the relief of inflammation and conversion to a pro-healing and pro-regenerative response can occur in a more normal way, because the body's actually helping drive this system.
Okay, so where I was going with that is it's illegal for you to do that in the U.S., correct?
Yes.
Okay. Have you had anybody have any bad side effects to what you're doing there?
We've had, in all the patients we've treated, which is over 300, we've not had a single adverse effect from the treatment itself. We had one patient out of all those patients that had a reaction to the skin prep material that we didn't know about and the patient didn't know about, and we didn't actually discover the cause of the rash that the patient had until a year later, when she came back to have a second procedure, and we skin tested her for the skin prep, which is the only thing that we had not yet tested her for after she had a skin rash. So no, we've had no adverse reactions, knock on wood, as a consequence of the treatment.
So it's a really safe procedure is where I was going.
Yes, and I say that hesitatingly because in 35 plus years of orthopedic treatment, there was not any single procedure, including a steroid injection, that I didn't have at least one adverse reaction to. But so far, we have not had that adverse reaction with our stem cell treatments.
So what, okay, now, the FDA is not allowing this, but yet they allow tissue that's harvested off of people that have passed to be surgically implanted into the body. That kind of, I don't know, that's confusing to me, why they won't allow what you're doing in the U.S. But, so what are the results of your 300 plus patients?
Well, I think they're doing really well. In trying to tabulate those results, we're in the 90% range with almost every protocol in terms of patient improvement and the patient feeling that they benefited from the procedure. The statistical evaluation is for us to be super specific about cartilage thickness, regeneration, some of the objective measurements that we take prior to each treatment are limited somewhat by the fact that the distance keeps people from necessarily coming back to have a re-evaluation in an objective way, which would require them traveling to see us, and so we don't have those objective reports, but the results that I've mentioned to you are based on the patient's evaluations and questionnaires that we do send out. And we use a visual analog type of questionnaire that is statistically relevant, so in the 90% range. And it varies between 90% and 94% depending on the joint area and depending on the nature of the problem.
Let me ask you a question here on all of that, okay? We have the opiate crisis in the United States. You've heard about that.
Yes.
Okay, I personally have back pain, have had it for years, but I had surgery, and I'm not going back for another round of surgery. Here's my question to you. I don't want opiates. A lot of people out there don't want the opiates, but how does this help with the pain level?
I'm not quite clear on your question. Are you asking about how is the treatment we provide going to help with the pain level?
Exactly.
Well, interestingly enough, we have treated several patients that have been on opiates and also on other sources of pain relief, fentanyl patches and methadone, and the most dramatic circumstance that I can remember is one gentleman who felt like his whole life was ruined, and he had back trouble. He'd had operations. All of them had, in his mind, had failed, and he was seeking our help as a last resort, and we treated him, and 48 hours later, he came back into the office smiling, told us that he hadn't had a pain pill or any type of pain medication in 24 hours, and he felt like that we had finally found his source of pain and we had removed it.
You're actually getting a benefit from these treatments that you're doing.
When you look at chronic pain, as you well know, it's multifactorial. And the thing that we're sort of discovering is that the scar tissue and inflammation that can still reside in an area of prior surgery and or in the area of injury that doesn't trigger a injury to a disc or a fracture that can be seen on special tests, that a lot of times these types of injuries are overlooked by even tests as specific as MRIs. And by identifying the areas of tenderness and inflammation that a patient may have, and then confirming, clinically determining where that area of tenderness is, and then confirming that there's something there that can be treated with ultrasound, and then targeting those areas, we're finding that patients frequently will get relief from the treatment. So it's actually, I don't think it's magic. It may seem like magic, but the body's been trying to heal that area probably ever since the injury occurred, and it just needs help. And all we're doing is supplying the materials that the body can use to then go ahead and heal that area. And that doesn't mean everybody's going to respond in such a positive way, but the results we're seeing indicate that a large number of individuals with chronic pain can, in fact, respond appropriately. But only if you have that combination, identifiable clinical signs combined with a visible area of scar or inflammation.
Okay. So when these stem cells go into that area, what are they actually doing?
That's a great question, and I think that I'm going to have to, sort of like how the universe was created in a sense. I think there's some magic that none of us really understand. We can all pretend like we do understand it. But what's happening is that you have a stem cell that maybe, say, is mesodermally differentiated so that it can develop into muscle, tendon, ligament, bone, articular cartilage. And that stem cell is placed into the area of scar inflammation or depletion of those resources. We're also supplying the growth factors and the cytokines, and we're also applying the extracellular matrix. And then there's a terrific signaling event that takes place that the stem cells are reaching out to each other, both as the cells are placed into this area, they're seeking direction from the local site the local site is also trying to summon and direct the stem cells to the location they need to go, and all these other factors are contributing to the so-called construction process, if you will. So it's as if everybody, all the workmen, meaning the local tissue that is depleted, had been waiting for the materials, and now the materials are present, and now the construction is starting to take off at an accelerated pace. And that's the simplest way I can sort of describe what I think is happening.
Okay, so let's think of it this way, okay? Easiest way that I can come up with to figure this out, we've all seen what happens when we have a cut on our arm. It takes, and all these tissues come in with the blood and whatnot, and they rebuild it, and they seal up we might have a scar, but it's there. It's fixed.
Right.
So what you're saying is, a lot of times, and I'm trying to make this simple because I know if I can't understand it, my listeners aren't going to understand it. So we get the cut in the arm, and there is material from blood and whatnot to regenerate that tissue. You're saying that a lot of cases, like with discs and stuff like that, there aren't the materials there for the body to regenerate that tissue. Is that what I'm hearing?
Yes. If you take the disc per se, if somebody has had a disc surgery and the disc has been removed, then what happens is that, number one, there's scar from the surgery itself. Number two is that not having the disc material allows the vertebral bodies to come closer together, which then stresses the posterior elements, which include the joints in the spine. So you can then develop arthritis of those joints. And as that arthritis progresses and as the scar continues, it can limit motion, and that shifts stress to other more normal areas. And so the whole process can be a cascade of events that all started with the disc surgery, for example. Actually started with the disc injury. But there's evidence in disc surgeries that if the disc area was injected with stem cells at the completion of the surgical procedure, that it can decrease the tendency for the disc space to collapse, therefore can prevent some of the long-term consequences of losing a disc. And the other issue is that when the disc space is lost and the posterior elements become arthritis, then the next stage is a fusion. And so you get the progression of surgical treatments that can lead, to satisfying the problem at one level, but then transferring the stress to a level above or below. And that's not to mean that the surgery was not indicated. It's just simply the way it happens. So you get a progression of spine problems over time that can happen as a consequence of the first injury that led to the first surgery that led to the fusion that then led to the next stage, and on and on. But you can stabilize that progression of process somewhat by providing the materials that the body needs to try to actually heal the first downturn of events in a more healthy way, and can interrupt that progression that leads down the hill to a worse and worse and worse problem.
Okay, so you have a problem with your disc, and then all of a sudden what you do is you go for surgery, but the body is not able to provide enough material to repair that, so that spirals into more problems and more problems. I'm making it very simple here, but
yeah, in all fairness to the people that do the surgery, it's not a 100% guarantee that that's the path that an individual patient will take. But the patients that we see, that seems to be the path that they have had to take, is that very thing that you just described.
Okay, so that happens. We don't have treatment in the United States to prevent that, but we do at your clinic there in Honduras. So do you do the surgeries there in Honduras? Any of these surgeries?
No, I haven't done spine surgery in 30 years, and I have done knee surgery, shoulder surgery, elbow, ankle, almost all the other parts, hand, whatever. And we have combined surgical procedures with stem cell treatments and been absolutely amazed at the rapid healing and the ease of recovery from a surgical procedure when stem cells are added at the time of the surgical procedure. So I really feel that there is a real place for the simultaneous approach to a surgical problem or a mechanical problem that deserves a surgical treatment, and you can prevent some of the long-term consequences of a surgical procedure by improving the potential healing response at the same time with stem cells.
My listeners, a lot of them have chronic back pain, a lot of them had failed surgeries, a lot of them have had, you name it, they've got it. What's next for them? And that's why I wanted you to talk about this, is these stem cells sound like it could be an option.
I think so. First off, if they're at the plateau stage where they've had whatever treatment to date and they have had whatever studies that have led to the plateau of, we got to treat you for chronic pain, there's nothing else we can do. What we would suggest is if it's a neck issue or a back issue, is that if they have their more recent studies, they can send those to us by email. And if they have leg pain or arm pain that's referred from the area, neck or back, that a current electromyography study would be important to rule out some kind of neurologic component. And they can send that stuff to us, and if they're coming through a referral source or a group such as you champion, we would be happy to look at that information and then respond to the patient and let them know if we think we can help them or not. And we would engage the patient directly by phone and discuss the situation with them and offer honestly a true evaluation of the information they send us. They also should include any kind of clinical reports that they have, doctor's evaluations or whatever, so that we can try to help make sense out of the physician's side of the story also. And what we find out when we do that is sometimes the treating physicians have done everything that is actually rational to do that involves a surgical approach. But then there's maybe something else that we see that we can offer, like the treatment of scar, for example, or continued ongoing inflammation. So it doesn't mean that everybody can be treated that way, but it does mean that I'm sure that we can find some in that group that you've discussed with me that could benefit from what we can offer them.
Well, Dr. Terry, it's been a good morning. Do you have anything else you want to add real quick?
No, I really appreciate what you're doing for the sake of our veterans. I think One of the things that was impressed on me in my training is that sometimes the person with the least experience in the realm of what you are doing on a daily basis may actually have the best idea. And I've always kept that in the back of my mind. So even though you're a doctor of psychology, your embracement of the situation the veterans had and your stimulus to try to find answers to the problems that they are continuing to have in the face of being told that nothing else can be done is that voice of reason. So they're lucky to have you, and we're lucky to have you as well.
Well, I appreciate it, Dr. Terry, and I'm going to work very hard on getting a bunch of patients down there to you, okay?
Thanks, man.
All right.
Appreciate talking to you.
Thank you very much, Doc.
So thank you very much for listening to Veterans Heartbeat. We'd not be able to bring it to you without all the support of the listeners. And thank you again to Farside Signs for sponsoring the show. If you do need a unique vehicle design, swing on by and check them out. Also, thank you to our main sponsor, River. River has an array of services such as veterans-focused education, a vestibular disorder clinic, and now non-pharmaceutical treatments for pain, anxiety, and depression. Check them out on Facebook or on the web at riverofchange.org. Lastly, we'd like to show our appreciation to all of our veterans. Thank you for serving our country and keeping it safe.